Patients with metastatic non-small cell lung cancer receive immunotherapy as a standard of care, and with anti-PD-1 or anti-PD-1 immunotherapy. And people have retrospectively shown that patients whose tumours have a higher proportion of clonal mutations are more likely to have a clinical benefit from these treatments. And then more recently, people have demonstrated or suggested that subclonal mutations, both from retrospective analyses and from preclinical work, are associated with a diminished anti-tumor immune response. But no one's ever shown that prospectively. And so we set up the DARWIN II clinical trial in 2016 to answer this question of how important is intratumor heterogeneity for the response to systemic therapy for lung cancer. And at ESMO 2023, I presented the interim analysis of the DARWIN II study and of the first arm of this non-randomized umbrella study, where patients without an actionable mutation received immunotherapy, predominantly with Atezolizumab. And this study was different from other clinical trials in that we recruited patients from the longitudinal TRACERx trial. So this is a study where patients had a resection for their early lung cancer. The tumor was subjected to multi-region whole exome sequencing, and then these patients were followed longitudinally. And unfortunately, when some of those patients relapsed with metastatic disease, we approached them for participation in the DARWIN II study. And the primary and secondary objectives of the trial were really to look at what is the influence and association of markers of intratumor heterogeneity with progression-free survival and tumor response, respectively, with the hypothesis that patients with high clonal tumor mutation burdens would have increased clinical benefit from immunotherapy. And so we recruited 45 patients from within the DARWIN II study who received atezolizumab, and then another 25 patients had immunotherapy as part of the TRACERx trial, but outside of the DARWIN II study, partly during the period that the DARWIN II trial was closed to recruitment during the pandemic. And we presented the data of these 70 patients together as a single cohort. And I think it was important to highlight that different from the retrospective analyses that have been done, where people have assessed clonality and tumor heterogeneity from a single sample, we used multi-region whole exome sequencing for the patient's primary tumor, as well as the biopsy at relapse, to really have a really in-depth understanding of tumor heterogeneity and how important that was for response to therapy. And what we found at the time of this interim analysis, for the primary objective, which was investigator-assessed PFS, that clonal tumor mutation burden had a hazard ratio of 0.7 for progression-free survival, although the confidence interval spanned 1, so this was not at this time significant. And we presented an analysis of 48 of 70 patients where we had all of the multi-region and multi-omic sequencing data, because we have whole exome sequencing, RNA sequencing, methylation sequencing, TCR sequencing. And so we did some additional exploratory analyses for the primary endpoint that shows that high levels of transcriptomic heterogeneity and high levels of epigenetic heterogeneity are associated with shorter progression-free survival times, with a hazard ratio of 2.0, and they were both statistically significant. And then for the secondary endpoint of durable clinical benefit, defined as stable disease, partial response or complete response lasting for 6 months or longer, we find that clonal tumor mutation burden is associated with clinical benefit with an odds ratio of 5.7 in favor of clinical benefit, and that's for patients who have a high clonal tumor mutation burden, above 4 clonal mutations per megabase of DNA. And at this time, that was the only per protocol metric that was significant. And interestingly, the high levels of transcriptomic heterogeneity were the relationship between that and the poor outcome were maintained. We're actively looking at a wide number of different metrics to look at how that might influence the response to immunotherapy and how tumor heterogeneity influences that. But this is the first study to prospectively suggest that clonal mutations are associated with clinical benefit, and that high levels of transcriptomic heterogeneity are associated with reduced progression-free survival and reduced clinical benefit. And we look forward to presenting in publication form the analysis of the entire cohort with adjustments for known prognostic factors.